Dear students, today the lecture will be discussing the retention, stability, and support in complete denture and the factors affecting successful denture fabrication. The the factors that affecting successful denture fabrication related mainly to the psychological and physiological comfort for the patient, coming from three main categories, which are the retention, stability, and support to have a successful denture, which this highlight the longevity of using such a denture. Now, generally, the factors affecting successful denture fabrication are the biological factors and physical factors which affect retention and support. And in terms of retention, there is a psychological comfort by the patient, which lead to really become comfy to the denture to say that this prosthesis is a success. Now, the mechanical factor affect the stability, and this affects physiologically comfort because the stable denture give a comfort for the patient and a confident, so then the prosthesis success in this term as well. Now, also the physical factor affect the support and the longevity of the denture. So generally, all these factors affect the categories which give a comfort for the patient to say that these prostheses are actually successful. Now, starting with the first category, depend or rely on the successful denture and the factors affecting retention. What is retention? Retention, it is the resistance to removable or removal of the denture in a direction opposite to that of the insertion. Now, what are the factors that affecting retention? We have anatomical factors, physiological factors, physical factors, mechanical factors, oral and facial musculature, and psychological factors. So to start with the anatomical factors, first of all, the size of the denture bearing area. We know that in the maxillary edentulous arch, the surface area is larger than that in the mandibular arch, edentulous arch. So the size of the denture bearing area affect, of course, and this the anatomical landmark affect the retention as of course. Now the quality also of the denture bearing area, whether these with a hard bony structure beneath or flabby tissue. Of course, in the maxillary edentulous arch, there is a hard bony palate, while in the mandibular we have, for example, retromolar bud. It can be moved. Also, the denture bearing area shorter. The quality of the bone in the maxilla rather than the mandible. This will affect the retention as well and the support of the denture to give a retention. Now, the physiological factors also depends on the saliva quality and viscosity. We know that many patients, older patients, they have some diseases like diabetes, and this will affect the quality of the saliva. This become viscous or tobacco smoking patients, or sometimes there are variation in the quality and the viscosity of the saliva between the patients, and this affects the retention, of course. The thick saliva act as a separating between the denture and the tissue surface, while the serous and thin saliva layer affect as a media for cohesion and adhesion. We will discuss this later with the physical factors. Now, with the physical factors, the most commonly listed factors of retention include physical factors is the adhesion and cohesion. First of all, the adhesion it is the physical force involved in the attraction between unlike molecules, like that with the denture and the saliva, and the saliva and the underlying tissues. So the adhesion between them give really and increase the rotation for the denture. Now the cohesion, it is the physical attraction of like molecule for each other, like the relation between the molecules of the liquid between the two different surfaces, like the denture base and the tissue surface. We have also within the physical factors the interfacial surface tension. It is the resistance to separation possessed by the film of liquid between two well-adapted surfaces. And we can notice, for example, for instance, if we have two plates of glass and we can put a drop between them, so it will be difficult for us to separate these two plates in a direction away to each other vertically. But probably if we slide it from both sides, it will be easy to separate these two plates. Now, actual viscous tension refer to the force holding two parallel force together that is due to the viscosity of the interposed liquid. Now, viscous tension increase proportionally to increase the viscosity of the interposed liquid and increase in surface area covered by the denture. Now, the capillary attraction also is the force that causes the surface of a liquid to become elevated or depressed when it is in contact with a solid. The one of the other factors also that we have is the beside that of the capillary attraction and viscous tension, the atmospheric pressure, it is the physical factor of the hydrostatic pressure due to the weight of the atmosphere on the Earth's surface. And this also gives a chance to improve the rotation of the denture. Now, the other factor, the mechanical factor, this related to the undercuts within the edentulous arch, the rotational insertion path, and the parallel walls. And we also have the oral and facial musculature give a chance to have a rotation for the denture. Otherwise, if there is a problem with the muscles in terms of paralysis or some defect within the muscles, this will affect the rotation of the denture as well. Now, the biological factor, intimate tissue contact, it is the biological factor that refers to the close adaptation of the denture base to the underlying soft tissue. Now, the neuromuscular control refers to the functional forces exerted by the musculature of the patient that can affect the retention. Now, for the physiological effect and patient tolerance, it is important to have psychological acceptance for the denture. Otherwise, the patient, even the denture with all the details, planned to be a successful prosthesis, still the tolerance of the patient to this prosthesis and to accept to wear it and to deal with it and to consult with it, important to have a successful dental prosthesis. Complete denture is a mechanical object in a biological environment. So to ensure success of complete denture, the dentist must understand the physical, mechanical, and biological effect. Affect all what? The categories, starting with rotation, stability, and support. Otherwise, if we have a defect from one of these, on one of these categories, this will affect the others as well. Now, the second category is the stability. The stability is the resistance against horizontal movement and forces that tend to alter the relationship between the denture base and its supporting foundation in horizontal or rotary direction. In simpler words, defined as the quality of the denture to resist displacement by functional stress. Now, the the qualities necessary to create and maintain stability are depend upon many factors, starting with the retention. So, to have a stable denture, it is important to have first a retained denture. And then we are going through the other factors affecting this stability of the denture, starting with the diagnosis. Now, within the diagnosis, the dentist or the practitioner diagnose the patient mouth. Now, diagnosis consists of bland observation to determine and evaluate the existing condition, which lead to decision making based on the condition observed. Examination of a dentulous arch. It is essential to examine the patient mouth to find out if there is a planning for surgery or or somehow. We have intraoral examination, and this include heart palate. So. The practitioner should observe the heart palate in terms of there is a maxillary tori. If it is large, we need a surgical removal. If it is small, we need a relief, or we have a different design in complete denture. Or another option, soft palate, the extent between the hard and the soft palate, the residual ridge height, there is a resorbed, highly resorbed bone, or newly extracted teeth. Resurface examination, term of if there is actually maybe retained root or something like that. So we need to clean the area. Otherwise, this may be lead to cyst and ulcer under the denture. Arch form of upper and lower ridge, whether these are oval in shape, round, square, or V-shape. The undercuts that we have, what we would like us to, for the undercuts to be included within our design, or there are many undercuts we don't need it, so we relieve it or we exclude within our design. Now, the ridge relationship also should be examined. That means whether there's a class 1, class 2, or class 3 skeletal relationship. This will affect, of course, the our procedure in terms of setting of teeth, in whether in normal occlusion or lingualized occlusion or probably a cross bite. The frenal attachment. A highly frenal attachment may be needed to be removed by frenectomy or discluded from our design. The tongue, whether the tongue large or small, macroglossia or glossia, which affect, of course, the placement and the movement of the tongue, affect the position of the lower mandibular denture as well. Now, the saliva, whether the saliva viscous or serous, and finally mucosal examination, whether the mucosa thick or thin, which in which part we need probably different types of denture-based material. Now, the other factor is the denture-based outline. Within the denture-based outline, we have a labial flange extended from one buccal frenum to the another. Now we have also buccal flange extended from buccal frenum to the posterior most part of distobuccal area. In the maxillary denture, the posterior palatal cell area, the soft tissue along the junction of the hard and soft palate, on which pressure within physiological limit of the tissue can be applied by a denture to aid in the retention of the denture. Okay, now the we have the anterior vibrating line, which is an imaginary line located at the junction of the attached tissue overlying the hard pellet and the movable tissues of the immediately adjacent soft pellet. Now, the posterior vibrating line is an imaginary line at the junction of the aponeurosis of the tensor villi palatini muscle and the muscles portion of the soft palate. So, all of these should be determined by the denture base outline from all the directions. Now, in the mandibular denture, we have the distolingual extension of the lingual flange, which is the beginning of the seal area of the lower denture, should extend downward and backward from the retromolar pad at an angle approximately 45 degree. Now, the level of the floor of the mouth in its normal position is about the level of internal oblique line. Most of the movement of the tongue necessary to carry out its normal function occur above the mandibular teeth, but it appears that the 2 millimeter of extension below the internal oblique ridge provides necessary seal for these movements without the problem of overextension. So, as I mentioned previously, all of these points, we have the size and the form of the basal pellet or the basal seat. We have different forms in the basal seat. We have a square, oval, V shape, and all of these are necessary to find out how we can set the teeth on them. Also, the most important thing is the quality of the final impression. The quality of the final impression give all the details related to the stability of the denture. And probably now the occlusal plane, the maxillary rim, should be parallel anterior to the interbabillary line and posterior to the olectragus line, as that appears in the image. Now, plane should be parallel to the crest of the residual ridge. The occlusal surface in the region of the mandibular first molar are approximately 2 millimeter below the top of the retromolar pad. Now we have many important points to be highlighted within the occlusal plane. Now, the height of the occlusal rim conforms to activities of tongue, cheek, and corner of the mouth, which tend to enhance mandibular denture stability. Okay, now an added reference check: the top of the wax rim in the region of the mandibular first bicuspid should never be above the corner of the mouth. Now, within the occlusal plane, if the occlusal plane is too high, that means when the dental technician build up the occlusal rim and the occlusal plane too high, this will force the tongue into new position. That means higher position. This leads to loss of tongue accuracy, causes raise of floor of the mouth, and pressure on the border of the lingual flange, and then partially loss of the border seal. While if the occlusal plane is slightly low, causes no problem for denture patient, but if a occlusal plane is too low, this will lead to stabilizes the denture. At that point, we will move to the proper location and arrangement of the artificial teeth. Now the arch, that means the arch arrangement. It is used to indicate the buccolingual or buccopalatal relationship of teeth to either the crest of the ridge or the stress-bearing area. Now, we also have the instruction and education of the patient, regardless all the properties or all the proper following in these points, the instruction is essential for the patient to how to deal with the denture after insertion. This is important to give a comfort effect. Now we have also concept of neutral zone. The neutral zone is a potential space between lips and cheeks on one side and tongue on the other, where natural or artificial teeth are subjected to equal and opposite forces from surrounding muscles. Now, centric relation and centric occlusion provide stability to the denture. Now, the centric relation and centric occlusion is at same position. As I mentioned previously, the education of the patient is essential, as every patient should be informed regarding the care and proper use of his denture. Failure to heed the dentist device will eventually lead to damage to the supporting tissue. Now, it is usually obvious to them that their failure to master their denture problem is not the fault of the dentist, but rather the fault of their own inability to master the normal tongue position. Now, we have the last category in providing a successful dental prosthesis, or particularly a complete denture, the support. The supporting complete denture, the foundation area on which a denture prosthesis rests. With respect to dental prosthesis, the resistance to displacement away from the basal tissue or underlying structure is the support. Complete denture support is the resistance to vertical movement of the denture base towards the ridge. Now, support counteracts the forces at right angle to the occlusal surface directed toward the ridge. Now, what we have, or what the factors that affect the support, first of all, starting with the cover maximum surface. So the denture is extended to cover maximum. The effective support is obtained when the denture is extended to cover maximum surface area without bandaging on movable tissues. Now, also we have the tissue most capable of resisting resorption are selectively loaded during function. So probably to have a support denture, we should the denture should resist resorption. That means when the force applied to the denture, there is a distribution of the force. Do not focus on one part or in the denture bearing area, which affect the resorption. Now, the other factor as well, the tissue most capable of resisting vertical displacement are allowed to make firm contact with denture base during function, and this will give a functional restoration. And finally, compensation should be made for varying tissue resiliency. That means if we have a movable tissue, probably we can choose different denture-based material suits that. We have a main principles to put in our minds related to rotation, stability, and support of the denture. The basic principle of maximal extension is applied for support. It states that given a constant occlusal force, a broader denture bearing area, this decreases the stress unit area under the denture base. Now, decreasing the tissue displacement and reduces denture base movement. Other principles are the initial denture support is achieved by using impression procedures that provide optimal extension and functional loading of supporting tissues. And finally, the long-term support is obtained by directing the forces of occlusal loading towards those tissues most resistant to remodeling and resorptive changes. We also have For example, a mandibular anatomic consideration. For example, we have many landmarks should be put in our mind. Which affect this as well. The buccal shelf is recognized as a primary support bearing for the mandibular denture. Okay, it is usually covered by mucosa with an intervening submucous layer containing granular connective tissue and buccinator muscle fibers. Now, also the muscle fibers along the shelf in a longitudinal anterior-posterior direction. This permitting the denture base to rest directly on a portion of buccinator muscle without displacement. All of this with the buccal shelf area. Now, with the residual alveolar ridge, the patients exhibited broad or exhibiting broad, square, well-developed residual ridge covered by firmly bounded masticatory mucosa, plus a favorable intrinsic bone factor may rely on the ridges for support. And this for the mandibular anatomic consideration. Now, what we have with the, for example, the maxillary anatomic consideration, the hard palate, for example. Now, in the maxilla, the horizontal portion of the hard palate lateral to the midline raphe should provide support for complete dentures. The keratinized masticatory mucosa overlies a distinct mucous layer everywhere but at the midline sutures. So all the area keratinized, but also in the midline suture are not. Now, the submucosa contain fatty tissue anterolaterally and glandular tissue posterolaterally. This resilient layer acts as a cushion for the functional stress transmitted to the mucosa. So when the force applied to the denture, then this will lead to distribute the force all over the primary stress-bearing area, which is the ridge, and then distribute it to the full palate. Now, over the midline raphe, the mucosa is unyielding and must be relieved to avoid tissue management, because this is a soft tissue or thin tissue at this area. Now, the relief should be minimal to permit light contact of this tissue with the denture base under masticatory loading. Now, the residual alveolar ridge, the crest of the maxillary edentulous ridge is also important in complete denture support. And the soft tissue is often thick, keratinized, and firmly bounded to the periosteum and underlying bone. Now, we should put in our mind generally that the retention, stability, and support are very important features in complete denture fabrication that ensure the best possible treatment for the patient, carefully conserving what remains and replacing what is lost. So please, dear students, prepare yourself for the next week to have a quiz. Enumerate the factors that affecting denture retention and complete denture. I hope you get benefited from today's lecture, and thank you for today, and take care. We're gonna see you or discussing the next lecture next week. Thank you.